This is a case of a traumatic cataract in a middle-aged person who suffered penetrating injury with a thorn or a sharp object, and he presented to us with a ruptured anterior capsule and a traumatic cataract. Initially, I go ahead and make my 2.8 millimeter incision followed by 2 paracentesis wounds. I place an air bubble and put in trypan blue to stain the capsule. Once you do this, it's very easy to make out where the capsule has actually ruptured, and you can see it's right across the center. So there is one part where the capsule is fairly intact, one side. Now what I do is I just make a small nick, the superior part of that sort of intact capsule, and then with my Utrata forceps carve out a crude half rhexis. There is a small membrane out there, as you can see, going across from the pupil, and I cut that. I am now just trying to observe and see what exactly is going out on the other side. I just pull off this membrane and very gently I am looking exactly what are the areas, and I am doing a very gentle hydrodissection, and sometimes even this gentle hydrodissection can give you a hiccup. However, nothing untoward has happened, and I go ahead. I think there is a very, very small soft nucleus which is not going to come out with your bimanual. So I take my phaco probe and go ahead and phaco out that part. Once done, I switch to my bimanual and very carefully tease out the cortex, bring it to the center, try to bring it to the center, and only then aspirate. I then change hands and do the same for the other side. The other side is relatively easier. The trick in all these cases is you do not jump into the surgery as soon as they're present. You can wait a few days, and that's an advantage because the eye can quieten down a little bit and the cut ends of the capsule actually fibrose, and that helps you a lot. Once I am fairly sure that all the cortex has been removed, since I don't know where exactly the ends of the tear are extending to, I decide to put in a 3-piece IOL within the sulcus. I think this is the safest option. Using a Sinskey hook, I dial the trailing haptic into the sulcus. Make sure the iris is not caught up with the haptic or with the haptic, and then go ahead with my bimanual and aspirate all the HPMC. And if there is any loose cortex, I can take it off. There's nothing much here. Once done, I inject my intracameral antibiotic and hydrate the wounds. Thank you.